Welcome to all. Today we are talking about gastroesophageal reflux disease. Gastroesophageal reflux disease is the disorder where we have symptoms of heartburn, regurgitation, a salty taste in the mouth, and in severe cases vomiting. We take these symptoms seriously because they indicate underlying pathology within the esophagus, such as esophagitis, which is inflammation of the esophagus, ulceration, which can often lead on to the development of strictures. Now, very rarely reflux can be associated with the underlying development of Barrett's esophagus. What is Barrett's esophagus? Well, it's where the lining of the stomach often grows up into the esophagus, and this change in anatomy can be a risk factor for the development of esophageal cancer. Now have a look at this graph. In the top left you have the incidence of esophageal adenocarcinoma in males. In the bottom left you have the incidence of esophageal adenocarcinoma in females. Now this is a study in a Western country, and as you can see, the incidence of esophageal adenocarcinoma in males and in females is rising. This is thought to be linked to the increasing instance of acid reflux in these countries. Now look at the anatomy. The anatomy of the stomach. You have the esophagus coming down into the stomach at an angle. It passes the lower esophageal sphincter, which is often tight in the relaxed phase, but on swallowing can open up to allow esophageal contents to pass through into the stomach. As the food and drink passes into the stomach, it stays there, and after several hours will pass through the pylorus into the first part of the small bowel. Now, in patients who have acid reflux, what you often will find is that the contents of the stomach, whether it be acid or in fact liquid and food, will often reflux back up into the esophagus and cause symptoms. The most commonest symptom that we will often get is heartburn. There are certain things that aggravate heartburn, and this includes smoking, alcohol, and very rarely medications such as calcium channel antagonists. Calcium channel antagonists are medications which we often will use to treat blood pressure, but are known to lower the sphincter pressure and therefore increase the risk of getting acid reflux. Certainly, but there are many other risk factors for the development of acid reflux, the commonest of which in most Western countries is obesity. Pregnancy will also do it because it increases the intra-abdominal pressure. We've talked about smoking and alcohol, both of which will reduce the lower esophageal sphincter pressure. A hiatus hernia will increase your risk of the development of acid reflux symptoms, and we've talked about medication. Now, there is an infection of your stomach called Helicobacter pylori infection, and certainly in the Western world 40% of patients with esophagitis will have Helicobacter pylori infection. However, it is very important to understand that Helicobacter pylori infection is not associated with the development of acid reflux. Often you can treat the Helicobacter pylori infection and your acid reflux symptoms will not improve. What Helicobacter pylori infection is associated with is dyspeptic symptoms. That means that it is a risk factor for the development of gastritis, which is inflammation of your stomach, and gastric ulcers and duodenal ulcers, but it is not linked to the development of acid reflux symptoms. Very important to be aware of this. Have a look at this graph. This graph is showing the prevalence of Helicobacter pylori infection in developed countries and developing countries. Certainly you can see that in developed countries the incidence of the prevalence of Helicobacter pylori infection is low. Compare that to the developing countries, it is high. So certainly in most developing countries it is the norm to have Helicobacter pylori infection by the time you reach adulthood. This is a UK study. It shows the incidence of esophageal cancer is slowly rising in the UK. Now this is thought to be related to the fact that people are becoming certainly more overweight and are having increasing issues with acid reflux, which in turn puts you at risk of developing Barrett's esophagus and hence esophageal adenocarcinoma of the esophagus. Symptoms of heartburn are very straightforward. Within an hour of eating you will often develop symptoms of heartburn, or regurgitation or belching or an acid taste in the mouth, or possibly regurgitation of the contents that you've eaten back into the mouth. In severe cases, this can be vomiting. If you do vomit and you do have heartburn and you do have regurgitation, we tend to call this a volume reflux. Volume reflux is where there is a volume of contents coming back up the esophagus. On the flip side, you get something called silent reflux, or it is sometimes called laryngopharyngeal reflux. Now, silent reflux is where you get throat symptoms. Throat symptoms are often such as sore throat, lump in the throat, hoarse voice, a silent cough, recurrent clearing of your throat. Now, many people will have these symptoms, but actually, when investigated, it turns out that only 30% of such patients will actually have definite evidence of acid reflux. So we cannot always be absolutely sure that people with throat symptoms are having their throat symptoms because of silent reflux, and therefore this category tend not to respond very well to either medical or surgical therapy for acid reflux. You can get some atypical symptoms, which are unusual symptoms caused by acid reflux, and this includes dysphagia, which is difficulty with eating, or dynophagia, which is a painful swallow. As many dentists will often tell their patients that dental enamel loss and bad breath can be caused by underlying reflux. Well, the investigations that we often perform are a gastroscopy, which is a 5-minute camera test into the stomach. If that is not available, then the other option is to perform a barium swallow on meal, which is where barium is swallowed and x-rays are taken of the esophagus and the stomach, and this looks for any evidence of reflux up the esophagus, as well as a hiatus hernia, which is a predisposing factor for the development of acid reflux. The gold standard test, of course, is something called the esophageal function study, where a small probe is placed into the nose and down into the esophagus and left there for 24 hours. That will record the acid exposure in the lower esophagus and will tell us definitely how severe the acid reflux is and whether or not surgical anti-reflux surgery is an option. If this test cannot be tolerated, another option is to consider a wireless Bravo study. This is a picture of someone having a Bravo capsule attached to the lower esophagus, and this measures over the course of a few days the acid exposure in the lower esophagus. Now, have a look at these slides. Slide A is the normal anatomy of the lower esophagus. Slide B is the typical appearance of the development of Barrett's mucosa, where the gastric mucosa started to move up into the esophagus. Barrett's esophagus, we know, is a risk factor for the development of adenocarcinoma of the esophagus, and therefore many countries will often survey these patients on a regular basis by offering them regular gastroscopies. Now, if you ever do have a gastroscopy performed and on the report your physician may write that you have either a normal esophagus or grade A, B, C or D LA classification. This simply stands for the Los Angeles classification of esophagitis, with A being mild esophagitis and D being severe esophagitis. Many patients will want to know how best to improve their symptoms. This is, again, usually straightforward. If you smoke, you stop. If you drink, you stop. If you are drinking much carbonated drinks, whether it be 7-Up, Sprite, Coca-Cola, you must stop and reduce this consumption, and I'll talk about that in the next slide. Elevate the head of your bed so that gravity will keep things down, and try not to eat big large meals, especially prior to bed. If anything, you should eat regular and small meals. This is a table looking at the acid rather than acid, what I actually mean is looking at the pH contents of a variety of substances. Water has a pH of 7, anything less than 7 is acidic. Down at the bottom you have battery acid, which has a pH of 1. Not much above that is Coca-Cola with a pH of 2.4, Pepsi with a pH of 3, Red Bull with a pH of 3.3, milk has a pH that is slightly acidic at 6.7. This shows quite clearly that if you are drinking carbonated drinks, you are exposing your esophagus and your stomach to an increased level of acid. If you have reflux, you must stop drinking carbonated drinks. Now, there are medications that we often give to reduce acid secretion, and you don't need to really get to know this slide very well. Essentially, we call them proton pump inhibitors, and these medications such as esomeprazole, omeprazole, lansoprazole, pantoprazole, rabeprazole, they come under many variety of names. They essentially stop the excretion of acid into the stomach. Now, they are best taken twice a day because they often will have a short half-life of no more than a couple of hours. They work best when they are taken 30 minutes prior to a meal. So if you're not taking your proton pump inhibitor before your meals, well, you will continue to have symptoms. Now, they are safe. There is a slightly increased risk of developing hip fractures with these medications long term, but the increased risk is only ever slight. There is a slightly increased risk of you developing pneumonias on these medications, but again, that risk is ever so slight. There's also a slight risk of developing something called Clostridium difficile diarrhea, which is a diarrhea due to an infection from the Clostridium difficile bacteria, but again, that increase of risk is only ever slight. Very rarely it can be associated with a very low magnesium. Now, if you cannot tolerate proton pump inhibitors, then the other options are to use a type of medication called H2 receptor antagonists, one of which is called ranitidine, and this is a medication which in many Western countries has been withdrawn due to some concern that there is a carcinogenic risk, but there are some related medications such as famotidine or cimetidine. Now, these medications were around many years before the development of proton pump inhibitors, and these H2 receptor antagonists can work well but have a problem called tachyphylaxis. Tachyphylaxis is where the longer you take this medication, the less effective it is, and so you do really need to take a drug holiday for a few weeks every now and then to regain the effect of these medications. Now, the other option in terms of treatment is the use of an alginate such as Gaviscon or Peptac, and these alginates work by forming a raft above the gastric contents, and certainly this raft will prevent any acid refluxing up the esophagus. Here is an endoscopic example of the ingestion of an alginate. In slide A, you see the initial picture taken not long after the alginate has been ingested, and a few minutes later in slide D you can see that a foam has developed above the gastric contents, and if reflux happens, this raft is non-acidic and therefore will protect the lower esophagus from exposure to acid. If these medications fail to work, the other options include what we call prokinetics. Prokinetics are medications which will increase your gastric emptying rate. Now, these do not come without their own risks, side effects. Metoclopramide, certainly in the UK, has been advised not to be used long term because of the risk of neurological side effects. Domperidone, again in the UK, has been advised not to be used long term because of some small risk of cardiac arrhythmias. Procalcipride is a medication often used for constipation, but it has a side effect, therefore, of course, diarrhea. Now, very rarely you could use a medication called baclofen. Baclofen is a GABA B agonist and will reduce the frequency of reflux events because it will prevent the transient lower esophageal sphincter relaxation from occurring. This is an unlicensed use and is often tried in those patients who have failed all other medications. If medications really do fail, then the last step is to be considered for anti-reflux surgery. Anti-reflux surgery is a simple, safe technique and works very well. The new kid on the block is something called the LINX procedure or the LINX system. This is a system where you have a ring of metallic beads. These beads are placed around the lower esophagus. When food therefore is pushed through the esophagus, the link system will distend and allow food to bypass it, but then the magnets will ensure that the system then contracts into a tight system, so food residue or liquid residue cannot reflux back up through the lower esophageal sphincter into the esophagus. The only con with the use of the link system is that there is some concern as to the safety of the use of an MRI scan once the links system is in place. With regards to future developments for anti-reflux treatment, well, there are many drugs that are in the final phase of trials looking at prolonging the half-life of the proton pump inhibitor, but also drugs that have a dual release mechanism, whereby an initial release is in the proximal small bowel and a secondary release is in the distal small bowel, and no doubt these medications will make a significant impact and improvement on the current treatment options that we have available. Development is the salivary test for pepsin. Now, pepsin is an enzyme produced from your stomach, which should not be present in the mouth, and if you do have pepsin in the mouth, then that does suggest the possibility of reflux. Now, this test has its supporters, but whether or not it will be of any clinical use over time remains to be seen. And finally, my last slide, very simple. We really do need to ask patients who are having issues with acid reflux to try and lose weight, to try and stop smoking, and to try and reduce their carbonated drink intake and their alcohol intake. If they are on proton pump inhibitors, they do really work best when they're taken 20 to 30 minutes prior to meals. Well, that's the end of this presentation on gastroesophageal reflux. I hope you have enjoyed the presentation. Please do subscribe to the channel, and I will see you on the channel for my next topic.